Thank you, Dr. Noach, for your time today. So tell us, how do you get to that staggering figure?
Thanks very much for having us. And yes, it is a large number, which in some respects could actually be very good news if we are achieving some level of immunity. Actually, the way that we've got to that number is we've worked backwards from the publicly available data from the South African Medical Research Council, which has reported on the excess natural deaths that have been recurring through COVID-19 around the country and this period. If you look carefully at the Medical Research Council data, it goes back quite some distance, so it's good longitudinal data that shows what the expected number of natural deaths should be for this time of year. And if you look just in the COVID period, you see a sudden spike in the natural deaths occurring during this period. That spike is out of kilter with the patterns over previous years, is related only to natural deaths, so these are not trauma-related deaths, and as a result could really only be attributed to COVID-19. I should make the point that many countries in the world, almost every country in the world, has reported greater excess natural deaths than the actual COVID reported deaths number. And this is because in order to attribute a death directly to a COVID death, one needs to have a pathology result showing that the patient was COVID positive. So this is not an unprecedented situation, and many developed economies and countries and healthcare systems have had the same situation. So if you take that Medical Research Council data and you assume that 90% of the excess deaths, being quite conservative, so not attributing all the deaths, but saying 90% of those excess natural deaths related to COVID-19, and then you apply the infection fatality rate or the actual fatality rate of COVID-19 to that data, a simple mathematical model allows you to extrapolate backwards what the total number of infections would have been in order to cause that mortality. And one gets a confidence range of somewhere between 9 million and 18 million deaths. And we think the most likely is around about 13 million deaths.
Yeah. So just to clarify for us quickly before we carry on, Dr. Noach, what is South Africa's fatality rate? Is that based solely on global figures, or does that number diverge slightly for our country specifically?
It diverges for different countries based on average age. That's the primary determinant. And then the second most determinant is the prevalence of chronic disease. This infection fatality rate, or IFR, is published by the Imperial College of London with certain adjustment factors for age and chronic disease, and supported by a second article, which was a seminal article published in the Lancet Journal, where a group of authors also determined the infection fatality rate. We've taken those two global pieces of research and we've applied them to the average population dynamics or demographics in South Africa. And the infection fatality rate is somewhere between 0.3 and 0.4. In other words, 0.3 to 0.4% of people who catch COVID-19, all people, not only reported infections, all people will result in death. And that is sensitive to age. A very interesting factor is that we've seen the infection fatality rate change during the disease in South Africa, and we've seen that in our own data. Now that we have much better skills and treatments to treat COVID-19, we've seen lower ICU mortality rates, we've seen higher survival rates, and so the infection fatality rate has actually come down.
So you've said that this is the similar scenario is true for all countries across the globe who've experienced COVID-19 as we have. What would the impact then be if you extrapolate that equation to the global numbers?
Yeah, I don't know about all countries. That would be too big a statement for me. But many countries have gone public and declared this. One good example is in the United Kingdom. They were tracking the death count, and then at a point in time stopped and said, actually, the excess natural death tracking is showing a much higher number. They think there are a large number of deaths. In their case, it was in care homes, frail care homes and elder care homes in the United Kingdom, where the deaths were directly attributed to COVID-19. But much like the South African data, were complete outliers on the statistical norms around the corridor of certainty. And so in that market, they did that. So that's the kind of trend that we're seeing. I'm unfortunately unable to extrapolate what the total global numbers would be. It's a good question. I'll certainly be sure to ask the actuarial leaders that same question.
I want to get your thoughts on a second wave here in South Africa. We're seeing a number of European countries experiencing that second wave. The UK is preparing for its second wave, launching a number of stricter regulations from this morning to try and curb the spread or a second wave of COVID-19. What is the likelihood and the time frame and the modelling looking like for South Africa's second wave?
It's an extremely difficult question to answer, and there are so many unknowns in this disease. The most important and most responsible position to start off with is to say that we should not drop our guard. We've heard our Minister of Health and our President urging all South Africans to take appropriate non-pharmaceutical precautions. Social distancing, wearing of a mask because of the very high asymptomatic rates, religious hand washing, prudent hygiene precautions. One has to answer this question every time by saying, you've heard those things many times, please continue to do them. It is critically important. We are concerned by the signs of what we're seeing around the world. Many countries now, as you say, the United Kingdom, but Spain and France are leading the European second wave. We've seen Israel go into a second formal lockdown as of this weekend. We have a very widely publicized second wave in the United States. And there's no reason to believe that we would necessarily be immune. So one does need to be cautious. It seems that the typical gap between the two periods is roughly 2 months and may be related to people no longer taking the precautions they were taking when the focus and intensity of attention was so great on it. I think the one thing that does stand South Africa in very good stead is that the seroprevalence studies that we're seeing, particularly the most recent data published by the Cape Metro, supported by UCT Medical School, is showing in the antenatal clinics in the Cape Metro a seroprevalence rate, in other words, positive antibodies, in about 37 to 40% of people. Now, that's much higher than has been reported in many other parts of the world. Even Sweden, who didn't have a formal lockdown, are not reporting antibody rates that high. And so it does seem that there has been a broad exposure, in particular areas where people live very close together. The exposure seems to be higher than in other parts of the world. And if this is the case, and the immunity does prove to be long-lasting, this could stand us in good stead.
South Africa had a very strict initial lockdown, and that extended for quite a number of months. And a lot of people are saying that's exactly why our mortality rate is so low, that we can attribute those lives saved directly to our lockdown. But unfortunately, because of the cost of that lockdown, we're no longer in a position economically to continue to have that lockdown. In your opinion, is mask wearing and hand washing and social distancing amid your normal daily activities enough to prevent that second wave?
I very much hope so. And there is very good evidence to show from very disciplined economies, particularly in the East, that where appropriate non-pharmaceutical interventions are taken, there is a direct relationship between that and flattening the curve. And there are examples out of South Korea, Hong Kong, and China, where these very disciplined economies, where mask wearing is ubiquitous and mandatory, where hygiene precautions are ubiquitous, where people bow to greet rather than shake hands, and so there's less physical contact. There is evidence to show that in these economies that has flattened the curve. So without a doubt, it is the single most important message you could give viewers and the most important thing that we can do.
Now, given the fact that our numbers have decreased significantly, we've seen the decommissioning of field hospitals. We've seen many private and public hospitals returning to slightly more normal procedures where elective procedures are being allowed. Do you think if we do see a sudden spike in cases that our medical community and facilities will still be ready to react?
I very much hope so. I would say that we've learnt significant lessons and created a much more agile preparedness. This was one of the big advantages of the extended lockdown, was that the infrastructure preparedness that we managed to achieve before the regional outbreaks happened significantly supported us and without a doubt reduced the mortality rate during this period. We're not aware of a single Discovery Health Medical Scheme member who didn't have immediate access to the type of care that they require when they were COVID-19 positive. And so, unlike what we saw in places like New York and Italy, where they have very developed healthcare systems, our system was not overwhelmed. I think that we are in a much better position to gear up if that's needed. Along with you, I very much pray and hope that we do not have a second wave.
All right, thank you very much for your time. That was Dr. Ryan Noach, Discovery Health CEO.